Okay, hello. It's Dr. Marston, of course, with our fourth class here. And this week we are going to be talking about depression. So I'm just going to, um, video lecture, I'm going to be talking about depression and cover as many uh, topics as I can about depression. Okay. So what I want to do is I'm going to talk about what depression is and then talk about um, the common diagnoses associated with depression, and then talk about some of the theories about where depression comes from. I know that from the readings for this week, you've got a lot of information about the different um, uh, the different types of stressors, the different types of environmental factors, the different types of um, neurochemistry that contribute to depression. I'm going to be talking a little bit more about some of the other specific theories of depression and also what the formal diagnoses of depression are. Um, so, generally, let's talk about what depression is. Um, a lot of times anymore, you will hear commercials for psychiatric medications or different discussions of depression that will start with depression is not just sadness, and that's true to a large extent. But it's also worth keeping in mind that depression is not sadness either. In other words, sadness makes up a large part of depression. People who are depressed wouldn't describe themselves as happy. Um, so there is a large degree to which uh, depression is sadness. It's sort of a pervasive sadness. And that's probably the sort of general sense of how depression is described by people who have depression, regardless of where it might come from or what some of the factors might be contributing to depression. The bottom line is depression is understood to be essentially a pervasive level of sadness. Sadness is often expected to be something that occurs but then goes away after a certain point of time. So sadness is expected to be, for the most part, um, uh, temporary. You get sad in a certain type of situation, and then the sadness goes away after things get better. And the thing about depression is why it often catches people as a problem, why it often catches them off guard, why it can often be overwhelming is that it is typically seen as a level of noticeable depression that does not go away, even after the thing that made the person sad sort of has resolved itself. Um, Examples: you try for a job and you um, don't get the job. Typically, you would be sad about that, and everybody would understand that you feel sad. But at a certain point, it would be expected that you would come out of that sadness. You would quote unquote get over the sadness, and that's not a sort of blanket statement about uh, you know a judgment. It's not judging the person saying, "Well, you got to get over it." That's just the expectation. The expectation of all people when they deal with something where they're sad is they suffer the sad situation, they feel sad, and then the sadness dissipates. It goes away. The person, quote unquote, gets over it. Um, and sometimes the quote unquote getting over it takes a long time. Grief is a good example. A a close family member passes away. You are going to be sad, and you are going to be sad for a while. a person loses a spouse that they've been married to for 50 plus years. That sadness is expected to be intense, but the sadness after a while is expected to go away. Not that the person forgets the loved one, just that the sadness is expected to sort of dissipate as the person realizes that life moves on without the other person, and they can carry their memories of the other person and their thoughts about them and take with them things they learned from the other person and gained from them. But the expectation is that the sadness as an intense emotional experience will eventually go away. In depression, when depression is considered to be a disorder that would be called a depressive disorder, that occurs when the sadness doesn't go away as quickly as one might expect. It continues to impact considerably on the person's functioning and interferes what they do. So depression is often considered to be a disorder, a pathology, when it either lasts for much longer than would be expected or impacts more than would be expected on the person's functioning. So it may be the person loses a loved one, and maybe right after they are still very sad, but that sadness manifests itself in the person not being able to go to bed, missing work for a week or two because they just can't motivate themselves to do things, stop eating, stop sleeping. So depression becomes a disorder when it either lasts for longer than might be expected, or when it impacts so much on the person's functioning that they can barely do anything, even after just a short period of time. Some of the symptoms that are associated with what is called depression include sad mood, just talked about that, loss of interest or pleasure, feelings of guilt, low self worth, disturbed sleep, disturbed appetite, low energy, lack of motivation, and poor concentration. A little statistical fact here. Um, Depression is considered to be the leading cause of uh, disability uh, throughout the world, um, and is considered to be um, the second uh, major contributor to the negative impact of disease throughout the world. So, what that second part means is the World Health Organization will measure the impact of different diseases uh, in terms or of the World Health Organization will measure the degree of different pathologies, different diagnoses in terms of the impact they have in how much uh, disease there is in the world. And depression is considered to be the second leading cause in all of the world. Uh, some of the estimates about depression is that it affects about 121 million people throughout the world and is as I said, the leading cause of disability throughout the world. So um, I'm just moving through my notes here. Uh, so as I said, uh, I talked about the symptoms of depression, and there are several different causes of depression. Genetics. So genetics would be where the person is biologically predisposed to suffer depression. Biological, different uh, biochemical factors contribute. This could be genetic or it could be the result of other factors. So there's genetics, biology, Certain dietary patterns will tend to increase depression. Environmental factors can contribute to um depression. Sociocultural factors, different aspects of the person's relationships or the situations they find themselves in, and personality can also be a contributing factor um, to depression. So all of those are considered to be um, the different types of factors that can contribute to depression. I'm going to talk later about the different specific causes of depression, different diagnoses. I thought, um, just because it's where I have this in my notes, I thought now would be a good time to talk about the different types of therapy that can be used for helping to treat depression. Cognitive behavior therapy. Um, Cognitive behavior therapy focuses on helping the person restructure their negative thinking, as negative thinking is often seen as a contributing factor to depression. Cognitive behavior therapy would also look to change the person's behavior patterns so as to increase the frequency with what the with which the person engages in behaviors that are likely to improve their mood. So that is more the behavioral part of cognitive behavior therapy. Um, so when you consider cognitive behavior therapy as a combination of both cognitive and behavioral, what you would be looking for is to alter the person's negative thinking patterns and then also alter the person's negative behavior patterns. Change their negative thinking and then change their behaviors, and both are seen as contributing to depression. Another type of therapy that's often used for depression is called interpersonal therapy. The issue there, interpersonal therapy is actually considered to be sort of a form of psychodynamic therapy, uh, but is a form of psychodynamic therapy that has a strong behavioral component to it. I'm going to offshoot here a little bit. Psychodynamic therapy, as I said earlier, is considered to be the modern form of what was considered to be psychoanalysis. And psychoanalysis worked on addressing negative conflicts that the person had internally between basically how they wanted to be and how they wanted to act and how they know they're supposed to act. Um, And so oftentimes that causes a lot of internal struggles where the person is sort of motivated to want to act a certain way, but um, is sort of stopped with their understanding of how they're supposed to act. Very basic example of what might come up in psychoanalysis, with that sort of conflict is uh, someone may want on some level in what is called the id area of their psyche, want to eat donuts and pizza every day for breakfast, lunch, and dinner. That may be what, all they want to eat, donuts and pizza. But their understanding of how the world works and how things should be done and what is healthy sort of runs smack into their desire of how they want things to be. So the id is how they want things to be, donuts and pizza. The superego is this other part that sometimes is called the conscience, and that holds the very set rules of how you're supposed to act. And the conflict comes together in what is called the ego. So there's the id, the superego, and they come together in the ego. and the ego sort of tries to mix them together. In this example, might be, um, I want donuts and pizza all the time. Uh, super ego, you have to eat healthy all the time. You have to follow a healthy diet. And where they might meet in the ego is the ego might say, well, I can't have pizza and donuts all the time, but I can have them sometimes. An example of someone who might even be on a diet is a lot of times people on diets will have, um, I apologize there. Something came up on my screen and caused a small pause. I apologize for that. And I apologize. I'm having a little bit of disruptions with my security system on my computer. Hopefully, it won't interrupt us again. Um, but where you might see, um, sort of like an example of where the id and the superego kind of come together in the ego is very often people are on diets will have what is called a cheat day, where they may be saying, okay, 6 out of the 7 days per week, I'm going to follow this very strict and healthy diet. But one day during the week, I'm going to allow myself maybe to have a donut and some pizza. So the desire for uh, wanting to eat nothing but junk and the sort of maybe strict overall sense of you have to eat healthy, um, sort of come together and meet in the middle, and there's sort of a compromise within the ego. So, and those conflicts exist throughout the psyche. The problem with psychoanalysis, this is why I wanted to talk about psychodynamic therapy here, because it does come up. There was always a problem with psychoanalysis. And the problem with psychoanalysis is it is a very long process. Cognitive behavior therapy has, for the past several decades, been a much more popular form of psychotherapy. And it is a type I practice. And I would like to say that the reason that it became the most popular form of therapy now is simply because it's been shown to be much more effective than any other type. And to a large extent, that is true. Its effectiveness is found to be greater than that of other ones when studies have been done. But to be honest, one of the biggest reasons it was became popular relatively quickly, because it's only been around since like the 50s, is because it's much more time limited. Cognitive behavior therapy is often discussed as, you know, being complete within 20 sessions. Um, Psychoanalysis, when it was prominent back in the early part of the 20th century, could go on for 10 or 20 years. Um, so psychoanalysis was seen as not a viable type of therapy, not because it didn't make sense or didn't have some concepts that fit in with how we understood human behavior, but really because um, it just went on too long. People couldn't afford to keep going. Um, Even in modern times, insurance won't cover psychoanalysis in most states just because it goes on for such a long time. So psychodynamic therapy came about as a form of therapy that was used as a way of addressing the psychoanalytic concepts, the concepts that were important in psychoanalysis, but addressing them in a way that was much more time limited, that could be done in a more um, appropriate span of time rather than needing to go for years before the person saw real effects. Okay. I will make reference to that later on, but I just want to know that's where this whole extension with psychodynamic therapy came from. Interpersonal therapy is seen as a form of psychodynamic therapy, and it focuses on help people understand and work through troubled relationships that may contribute to depression. Um, so, um, so the concept there is that many of these difficult conflicts internally manifest themselves in problematic relationships, and that what interpersonal therapy um, tries to address is um, breaking out of the negative patterns that contribute to relationships being a problem. One of the main concepts in psychodynamics is that because these conflicts come about, and because these internal conflicts may come about at a very early age, many of these conflicts play out in relationship difficulties. And that the problem is that the person gets caught in a cycle. So they are responding to relationships. They are dealing with relationships. They are interacting with other people in the same problematic way throughout their lives. Um, and that um, what interpersonal therapy does is try to find a way of changing how the person interacts with other people. It could be changing a present relationship, changing how they respond to their parents, changing how they respond to their um, uh, spouse, or it may focus on forming new relationships. Okay, so there's interpersonal therapy, which is a form of psychodynamic therapy. There's cognitive behavior therapy. Um, Psychoanalysis, if we do go to psychoanalysis or just straight psychodynamic therapy, um, it will psychodynamic therapy, not interpersonal therapy, but psychodynamic therapy, will focus on trying to break uh, this negative pattern of relationships. And where psychodynamic therapy might differ from interpersonal therapy is interpersonal therapy would focus on changing how the person addresses um, relationships outside of the therapy session. Psychodynamic therapy will focus on the relationship between the therapist and the client. So the sort of bottom line focus of psychodynamic therapy is that the person plays out these internal conflicts through important relationships in their lives. And the therapy relationship is an important relationship in the person's life. So that psychodynamic therapy will often look for how the person is expressing their emotional conflicts through the relationship with the therapist. Um, Acceptance and commitment therapy, which is another type of therapy that I talked about before, for depression, will often focus on helping the person uh, understand um, who they are, understand what their values are, and will help the person accept those values um, and um, and find ways of expressing their values in all areas of their life, in all areas of how they deal with um, things. And oftentimes, a large part of acceptance and commitment therapy, along with other types of, is an issue called mindfulness. And mindfulness is sort of living in the moment and recognizing that not every negative thought needs to be responded to. So oftentimes, mindfulness for depression will be helping the person recognize when they are feeling negative and when they are saying negative things about themselves, but will also focus on the person not seeing a need to respond to those negative feelings, to those negative thoughts, just letting them be there. That the difficulty that often comes up with depression is when we say negative things about ourselves, like I am a loser or I am no good, then we often feel a need to respond to that, to do something about that, how we're how what we're saying about ourselves. To is to either challenge it or feed into it or something along those lines. And mindfulness takes a step away from that. So that the main way to respond to negative thinking is to just let it be there, but not respond to it in a way that gives it power. Okay, those are some of the different, also other types of therapy, of course, psychiatric medications. Um, and I'll give you, I talked about some of these before, but some of the different types of um, of antidepressant medications are selective serotonin reuptake inhibitors. Selective serotonin reuptake inhibitors. And those are called SSRIs for short. Some of the most common types of antidepressant used these days are SSRIs, and they include Prozac, Zoloft, Lexapro, Paxil, and Celexa. Prozac, Zoloft, Lexapro, Paxil, and Celexa. Um, Other types of psychiatric medications for depression, one is called tricyclics. Tricyclics, Tricyclics. Those aren't used as much anymore because their side effects were rather intense. And Another one, that older version, I'll just give you the initials, MAOI. MAOI. Um, those are very old. Those are actually the oldest types of antidepressants, and they're used these days only for unusual forms of depression or forms of depression that don't respond to other tricyclics. So the bottom line of all this is that I want you to keep in mind that I think is useful to know is that the most common type of depression medication are these SSRIs. Um, Okay, so let's move on. So those are the different types of treatment. Oh, actually, I should mention one other that isn't used that much, but is used for severe forms of depression. And um, though that is electro electroconvulsive therapy, otherwise known as electric shock therapy. And that is one that is used um, for situations where the person becomes comatose, like doesn't is not able to do anything, and or where the person just where the depression is impacting so much um, on the person's functioning that they can barely get out of bed or cannot do anything or something along those lines. So, uh, so that's where electric shock therapy has been around for a long time. It's not used that much, but it is used in very severe forms of depression. So, and basically what it is there are different um, electrodes, although sometimes there's just two electrodes anymore. Uh, and the person is giving a relatively mild shock that's meant to sort of um, push sort of some of the biochemicals in a different direction so as to lessen uh, uh, the degree to which that those biochemicals are causing depressive symptoms. Okay, so let's talk about the different types of depression, the different diagnostic categories. And what I like talking about this, or what I think is particularly useful to talk about here when we're talking about uh, depression, is this is a good starting place to sort of see how the criteria in DSM-5 are used when discussing depression. So let's start with major depressive disorder. Major depressive disorder involves um, criteria that meet the definition of a major depressive episode. A major depressive episode uh, could include uh, the specific definition of a major depressive episode is that you have to have 5 or more of the following symptoms, and they have to be symptoms that lasted for at least 2 weeks, and um, that uh, represents a major change from how the person was functioning before that 2 week period. So a major depressive episode is the person's function on this level, and then for at least 2 weeks, they start to function at a lower level. And by a lower level, it means 5 or more of the following symptoms are present. And those symptoms could include depressed mood, and depressed mood is defined as the person talking about feeling sad or hopeless or just giving up. Loss of interest or pleasure, the person shows a noticeable decrease in interest in things they used to find interesting, or is not finding things pleasurable that at one point in their life they likely did find pleasurable. Noticeable weight loss or gain, trouble sleeping, and this could be sleeping too little or sleeping too much. Agitation, agitated behaviors, or slowness in responsiveness. So being agitated or responding too little. Fatigue, complaints of feeling tired all the time. Complaints of feeling worthless or feeling excessive guilt. Decreased concentration, and thoughts of death or suicide. Um, Now, some other criteria that have to be met in order to have a major depressive disorder diagnosis is the symptoms have to be severe enough that they are causing distress, um, or significantly impacting in the person's social or occupational functioning. The symptoms cannot be attributed to a medical disease. Um, the symptoms cannot be associated better by another diagnosis. And in order for it to be major depressive disorder, there cannot be any evidence of manic or hypomanic episodes, because if that occurs, then it kicks into a bipolar disorder diagnosis, and we'll talk about that later. Um, so now the other thing to keep in mind about major depressive disorder is there are two types of major depressive disorder. Major depressive disorder is um, major depressive disorder can be single episode. In other words, this person's functioning on this level, then for at least a 2 week period, they're functioning on this level, and it just continues until the depression gets better. Or, and that's called major depressive disorder single episode, but there also can be major depressive disorder recurrent episodes, which means the person has this period of 2 weeks, then maybe their mood improves, and then they have another episode. So if they have two or more of these types of episodes where they have this depression, then they get better, then they have the depression again, that is called recurrent major depressive disorder. Okay. Another, so and also keep in mind that um a couple other things about major depressive disorder. Notice that one of the symptoms is psychomotor agitation. I talked about that before. In that way, anger can sometimes be associated with depression. Um, and so sometimes with depression, you may have what's called agitated depression. And that's where the agitation is more prominent. The person tends to get angry at people. They are exhibiting their depression by getting nasty with people and and angry um, with them quicker. They seem to be more on edge. So depression can sometimes manifest itself with a depressive disorder. Now, there's another diagnosis called persistent depressive disorder. Persistent depressive disorder. And this also used to be called dysthymia. It used to also be called neurotic depression. It is considered to be a milder form of depression that lasts for a longer uh, uh, period of time. It is considered to be a chronic type. This is somebody who seems to be depressed um, just for a long period of time. They may even be described by some people as always been depressed, just a gloomy or negative person, and that is persistent depressive disorder. Now, it's interesting that there's another form of depression called adjustment disorder with depressed mood. Um, and um, Adjustment disorder with depressed mood is when you have it's basically situational depression. Something has happened in the person's life, and it's clear that they're suffering depressive symptoms because of something major that has changed in their life. They are adjusting to something new, and that's contributing to depressed uh, mood. So typically, what you would have in these cases would be less than the five or more symptoms of depression. So it'd be the same symptoms of depression, but you'd have less than five. Um, or it just may be that you have more than five, but some of the symptoms are just milder. They don't impact on the person's social and occupational functioning um, as noticeably as they would um, with major depression. And then the difference between persistent depressive disorder and adjustment disorder with depressed mood is adjustment disorder with depressed mood is less than 6 months. So if it hasn't resolved itself within 6 months, it moves from being adjustment disorder with depressed mood into persistent depressive disorder. Okay. Now, where does depression come from? That's something I think I'd like to hold on more for class to talk a little bit more about that. Um, there is the cognitive therapy theory of depression. Um, and that is more that the person develops just a very negative thought pattern. Everything is sort of put in the context of being viewed negatively. There is the psychodynamic view, which is with um, uh, that what often comes up with depression is the person has these internal conflicts, and because of these internal conflicts, um, they become angry with themselves. But as a way of sort of punishing themselves for having these conflicts, for having these thoughts that are causing the conflicts, they become withdrawn. They sort of give up. Um, uh, the psychodynamic view of depression sometimes has been phrased as depression is anger turned inward. The person becomes angry at themselves for even having these negative thoughts, and so it all goes inside of them. There is the humanistic view, which is that depression comes about because the person cannot find meaning or purpose in their life, and rather than put pressure on themselves to do more to find it, they just sort of give up, and they figure, well, there's no point in trying to even find purpose because there really isn't any. I want to stop there as far as I'm because I really want to read your paper and see kind of your um, the sort of direction you're going when I read your self-reflective paper, and that'll give me more of an idea of what we need to talk about when we talk about the different causes of disorder beyond what's already in the book. So I think for right now I'll stop. I'm going to get to grading your paper here in a little while, and then we'll just pick all this up when we meet on Thursday. So I look forward to seeing you then.